Eric Strong from the Palo Alto VA Hospital and Stanford University. Today I'm going to be discussing exacerbations of chronic obstructive pulmonary disease, focusing on their diagnosis and management. Here's the outline of this lecture. As you can see, the discussion of management will be broken down into how to triage the patient to the inpatient versus outpatient setting, bronchodilators, steroids, antibiotics, and a few other issues. So, how do we diagnose a COPD exacerbation? Well, as with any disease, when diagnosing COPD, we should first focus on its symptoms. There's a group of pulmonologists that I'll be referring to several times today known as GOLD. GOLD is an acronym that stands for Global Initiative for Chronic Obstructive Lung Disease, and it represents a collaboration between the National Institute of Health and the World Health Organization. GOLD more or less provides the standard of care for all aspects of COPD treatment. They define a COPD exacerbation as an event in the natural course of the disease characterized by a change in the patient's baseline dyspnea, cough, and/or sputum that is beyond normal day-to-day variations and is acute in onset. Now, this is an interesting definition in that it implies that the condition can be diagnosed by history alone without physical exam or diagnostic tests. It suggests a doctor could diagnose a COPD exacerbation over the phone. The one major caveat that GOLD has left out is that these symptoms should not be better explained by an alternative diagnosis, which certainly would require an exam and some form of additional testing. Moving on from the history to the exam, what are the physical findings seen with COPD exacerbations? First, there is usually one or more abnormal vital signs, most commonly tachypnea, but tachycardia and hypoxia are also common. During chest auscultation, you can note wheezing or decreased breath sounds, what some refer to as, quote, poor air movement. Depending on severity, there may be visually obvious use of the accessory muscles of respiration, flaring of the nostrils, or speaking in short sentences. Some patients adopt what is known as the tripod position, in which they sit leaning forward with some of their upper torso's weight supported by their arms. If the exacerbation is very severe, you may see either cyanosis or altered mental status, which can be signs of imminent respiratory failure and usually require emergent intervention. It's always important to ask ourselves, is there any evidence in the literature for any of these signs? For example, there's sensitivity and specificity for detecting an acute COPD exacerbation. Unfortunately, no. But all that means is that we must be cautious about using the presence or absence of a specific finding to make or break our diagnosis. Now let's talk about some additional diagnostic testing. Which patients get what? So first off, what about a chest x-ray? Everyone. Everyone in whom a diagnosis of a COPD exacerbation is being entertained needs a chest x-ray. Why? Because if you remember, a COPD exacerbation can only be diagnosed if other alternative explanations such as pneumonia have been demonstrated to be less likely. What about an EKG? Once again, everyone, and for the same reason as a chest x-ray. Everything from myocardial ischemia to arrhythmias to pulmonary emboli can be suggested by an EKG and can cause symptoms which can be mistaken for COPD. How about an ABG? I'd say almost every inpatient. In practice, I've found this to be a little contentious, with ER physicians frequently claiming this is unnecessary. However, it plays an important role in triaging the patient to the appropriate ward, and has also been shown to be predictive of how much benefit a patient will have from positive pressure ventilation, which we'll talk about later. What about PFTs or measures of peak flow? Peak flow measurements are commonly checked during asthma exacerbations. Why not during COPD exacerbations? Well, pretty much everyone advises against this because of the observation that older patients in respiratory distress simply can't adequately comply with the test. Lastly, how about a sputum culture? This is actually quite debated, and I won't take the time to go into the details, but the bottom line is that the only patients who should get a sputum culture are those with risk factors for having an exacerbation triggered by a pseudomonal infection. We'll talk about those specific risk factors later on. One more thing I'm going to include in the discussion of diagnosis is the importance of identifying the trigger for the COPD exacerbation. COPD itself is almost always caused by decades of smoking, but we should also try to identify the specific inciting event for this particular exacerbation. The bacterial pneumonia may account for as many as 50% of all exacerbations, further highlighting the necessity of getting chest x-rays for every patient. Viral infections, specifically rhinovirus and influenza, are also common. Air pollution, in the form of sulfur dioxide released by power plants and volcanic eruptions, nitrogen dioxide from power plants and automobile engines, ground level ozone, which unlike atmospheric ozone is not good for us, and lastly PM10, which is the term for the EPA uses to describe all particulate matter in the atmosphere smaller than 10 microns. All of these are forms of air pollution that can trigger exacerbations. Another important trigger to recognize is non-compliance with medications. Lastly, a fair number of COPD exacerbations have no identifiable trigger, some of which may be due to unrecognized pulmonary embolisms. We'll talk about that specific issue near the end of the lecture. So now I will switch gears and talk about management of COPD exacerbations. The first management decision is whether to treat the patient as an inpatient or outpatient. The American Thoracic Society and the European Respiratory Society have produced a list of indications for inpatient treatment. They include a marked increase in dyspnea, altered mental status, worsening hypoxia, acute respiratory acidosis, lack of home support, inadequate response to prior outpatient management, an uncertain diagnosis, or the presence of high-risk comorbid conditions such as CHF, diabetes, chronic kidney disease, and cirrhosis. If you think about the typical patient who presents to the ER or urgent care clinic with a COPD exacerbation, you'll quickly conclude that it's the very rare COPD patient who lacks all of these features. So what about medications? First, we have the bronchodilators. For acute exacerbations, this category includes just two drugs, the beta-agonist albuterol and the anticholinergic ipratropium. Which one should you use, or should you use both? Well, let's look at some guidelines. The GOLD guidelines state, short-acting inhaled beta-2 agonists are usually the preferred bronchodilators for treatment of exacerbations of COPD. If a prompt response to these drugs does not occur, the addition of an anticholinergic is recommended. The ATS guidelines state, short-acting beta-2 agonist or ipratropium MDI with spacer or handheld nebulizer as needed. The up-to-date article on COPD exacerbations states, inhaled short-acting beta-adrenergic agonists are the mainstay of therapy for an acute exacerbation of COPD. So different guidelines don't provide identical recommendations. In practice, almost everyone prescribes both albuterol and ipratropium together up front, as there is almost no downside to this. The only consideration is the chronotropic effect of albuterol on the heart rate, but this is usually only clinically relevant for patients in atrial fibrillation. What is the evidence for using bronchodilators in COPD exacerbations? None. There are actually no randomized placebo-controlled trials of bronchodilators. The reason for this, however, is that the onset of action is so dramatic and their benefit is so universal that the anecdotal evidence is overwhelming to the point that no one would consider an RCT of these drugs to be ethical. So, while I can't be 100% sure that they help my patients, I certainly always prescribe them. A common question about bronchodilators is whether they should be administered by metered dose inhaler or via nebulizer. Here's a picture of a boy using an inhaler with a spacer, which is the wide blue tube between the inhaler and his mouth. The purpose of the spacer is to provide more time for the medication to be fully aerosolized in order to reach the more distal airways, and not all end up on the back of the patient's oropharynx. In 1997, there was a meta-analysis of 12 studies in which patients with either acute COPD or asthma exacerbations were randomized to an inhaler or a nebulizer. The analysis found that both were equally effective at relieving airflow obstruction. In clinical practice, however, we frequently use nebulized bronchodilators instead of inhalers during acute exacerbations. The reason for this is that effective delivery of medication via an inhaler requires adequate patient cooperation and the ability to use proper technique, which can be difficult if they are in respiratory distress. While efficacy of the nebulizer is independent of patient effort or technique. Let's move on to steroids. I find that use of bronchodilators is usually very straightforward and consistent, while use of steroids shows significant variation. The first question that comes up is whether to use a high dose of steroid, such as 125 milligrams of methylprednisolone Q8 hours, or a low dose of steroid, such as 60 milligrams of methylprednisolone once a day. The only thing to say about this question is that there are no trials that address it, and that expert consensus favors the lower dose except in the most critically ill. The next question about steroids is whether to give them orally or via IV. In a trial published in Chest in 2007, 210 patients with a COPD exacerbation were randomized to 5 days of either IV or oral prednisolone 60 milligrams, then switched to 30 milligrams followed by a taper. The chart here shows the incidence of the composite endpoint of death, ICU admission, hospital readmission, or intensification of outpatient therapy over the follow-up period of 3 months. As you can see, there is no difference between the two groups. Therefore, oral is preferred as it's more convenient and cheaper and allows for more expedited discharge. Next, how long should the steroids be given for? This is the most contentious of all aspects of treating COPD exacerbations. There is only one significant trial which attempted to answer the question. In 1999, 271 patients were randomized to 2 weeks of steroids, 8 weeks of steroids, or placebo. They were followed for 6 months for the composite endpoint of death, intubation, hospital readmission for COPD, or later use of open-labeled steroids. The chart demonstrates that the rate of treatment failure for both the 2-week and 8-week group was statistically the same, and both were significantly better than placebo. Unfortunately, this trial isn't really helpful today, since no experienced physician would ever consider 8 weeks of steroids for a COPD exacerbation. Instead, we now debate 5 days versus 10 days versus 2 weeks. Which duration is best? We just don't know. Another uncertainty is whether or not a taper of steroid is necessary. We also don't know the answer to that question either. So in summary, common treatment with steroids for a COPD exacerbation is 30 to 60 milligrams of prednisone for anywhere from 5 to 14 days with or without a taper. The European Respiratory Society and American Thoracic Society guidelines are more specific, but we need to acknowledge that this specificity is a result of expert opinion alone and not actual evidence. Now, let's talk about antibiotics. First, who gets them? In 1987, a double-blind RCT looked at 362 COPD exacerbations in which patients were randomized to 10 days of either placebo or antibiotics. It was found that the patients receiving antibiotics were more likely to have successful resolution of their illness. Interestingly, during subgroup analysis, the investigators found that the degree of the increased success rate was related to how many of the 3 cardinal symptoms of COPD were present. Remember, those 3 cardinal symptoms were dyspnea, cough, and an increased sputum volume or purulence. They found that patients with only 1 cardinal symptom had minimal to no benefit, while patients with all 3 symptoms had the greatest improvement. On the basis of this and several other trials, most pulmonologists recommend antibiotics to any patient with either 2 of the 3 cardinal symptoms or a severe enough exacerbation to warrant positive pressure ventilation. But which antibiotic to use? This choice depends on four factors: the severity of exacerbation, the likely pathogen, risk factors for poor outcome, and your institution's specific antibiotic resistance profile. Here's a chart I've compiled based on a combination of professional society guidelines and antibiotic resistant patterns found at my home institutions of the Palo Alto VA Hospital and Stanford Medical Center. With mild exacerbations and no risk factors for poor outcome, the major pathogens to worry about are going to be strep pneumo, H. flu, and Moraxella. I would consider azithromycin to be my first choice antibiotic. Acceptable alternatives include cefpodoxime, which has unnecessary gram-negative coverage and misses atypical coverage, and doxycycline, which suffers from increasing resistance to it from pneumococcus. With a moderately severe exacerbation or with risk factors for poor outcome, in addition to the above pathogens, we also need to worry about various gram-negative rods. Therefore, our antibiotic coverage needs to be broader. First line is amoxicillin clavulanic acid, commonly known as Augmentin. Second line treatment would be the respiratory fluoroquinolones moxifloxacin and levofloxacin. Lastly, with a severe exacerbation or in patients with risk factors for pseudomonal infection, you need to be even broader. What are risk factors for Pseudomonas among patients with COPD? There are four to remember. Hospitalization within 90 days, FEV1 less than 50% predicted, a previous sputum culture with Pseudomonas, or 4 or more courses of antibiotics within the past year. First-line treatment for these patients is piptazo, commonly referred to as Zosyn. Levofloxacin is an acceptable second-line agent. How long do we treat these patients with antibiotics? A meta-analysis of 7 RCTs, including over 3,000 patients, compared a 5-day course with a 7 to 10-day course in outpatient COPD exacerbations. As you can see, the risk of treatment failure was identical in both groups. However, the risk of drug-related adverse events was less in the short course. Therefore, 5 days of antibiotics is the preferred duration of treatment. Although, again, the study was done in only outpatients, it is certainly possible that patients requiring inpatient admission are sicker and might potentially benefit from longer courses. This is probably a good place to make the very important note that when I am discussing antibiotic selection and duration, I am referring only to those patients with a COPD exacerbation in the absence of clinically apparent pneumonia. If your patient has a clinically relevant pneumonia, that is a fever, elevated white blood cell count, and infiltrate on chest x-ray, then he or she should be treated with antibiotics according to the pneumonia guidelines. Now let's move on to a couple other important management issues. Specifically, inpatient oxygen therapy, non-invasive positive pressure ventilation, and concurrent pulmonary embolisms. First, oxygen therapy. There's a well-known association between high arterial oxygen levels in COPD patients and the development of hypercapnia. The classic scenario is one where a patient with baseline hypoxia presents to the ER with a modest COPD exacerbation and is reflexively placed on high amount of supplemental oxygen, only to become confused and somnolent 15 minutes later, at which point an urgent ABG confirms the presence of significant hypercapnia. This occurs as a consequence of 3 independent mechanisms. Probably the most important is the overcoming of hypoxic vasoconstriction leading to worsened VQ mismatch. The Haldane effect is also a contributing factor. Lastly, in patients with chronic carbon dioxide retention, there is a largely unproven hypothesis that ventilatory drive becomes dependent solely on the presence of mild hypoxia. When this hypoxia is corrected, the stimulus for the patient to breathe disappears. Because of all these factors, most experts recommend targeting an O2 saturation of around 90 to 92% in patients who are hypoxic. Non-invasive positive pressure ventilation is another important treatment modality to consider for patients with a COPD exacerbation, specifically BiPAP. Here's a picture to remind you of what this device looks like. It's essentially a tight-fitting mask that delivers oxygen-rich air under pressure, improving both the patient's oxygenation and ventilation. Some BiPAP masks fit over just the nose like this one, while others fit over the nose and the mouth. While it may look silly, and these masks are not known for being particularly comfortable, BiPAP can be a very effective way to drive down carbon dioxide levels. Exactly how effective is BiPAP? In a meta-analysis published in Chest in 2008, 14 studies were examined in which nearly 1,000 patients with COPD exacerbations were randomized to either BiPAP or standard care. The meta-analysis demonstrated that BiPAP significantly cut the risk of the patient eventually requiring intubation, with a relative risk less than half that of standard care. By nearly an equal margin, it decreased the risk of in-hospital mortality, and on average, decreased length of stay in the hospital by nearly 2 days. The benefit of BiPAP was shown to be really quite dramatic. I'll apologize that this next graph may seem excessively busy. However, essentially what it demonstrates is that the reduction in the risk of intubation was closely related to initial arterial pH. In other words, if the initial arterial pH was normal, there was no benefit from BiPAP. But the benefit was more pronounced the lower the pH was. The authors of the study didn't provide a specific cutoff, but from eyeballing the graph, it appears to be about 7.35. In other words, the lower limit of normal. Thus, here is another reason why most patients sick enough to be admitted to the hospital weren't having an ABG checked. It will help decide who should receive BiPAP. The probable link between COPD exacerbations and pulmonary embolisms didn't become widely recognized until 2009, when a meta-analysis of 5 separate studies found that the prevalence of PEs in patients with exacerbations of spirometry-confirmed COPD was 20%. This number was astonishingly high. I don't think anyone knew quite what to do with the information. Does this suggest, for example, that every patient with COPD needs a CT angiogram on admission? And what was the explanation for this observation? There are 3 basic explanations. 1, PEs can trigger COPD exacerbations, just like pneumonia and air pollution do. 2, COPD exacerbations promote the development of DVTs. Or 3, my preferred explanation, is that these patients don't have a COPD exacerbation at all, but that the PE's symptoms and signs are being mistaken for such. That PEs can trigger things like cough and wheezing are definitely underappreciated. Well, okay, regardless of pathophysiologic explanation, how do we determine which patients are at higher risk of having a PE? Of the 5 studies included in the aforementioned meta-analysis, 1 study showed that patients with PE were more likely to complain of chest pain and less likely to complain of cough or increased sputum production. Unfortunately, the other 4 studies showed no difference in symptoms. None of the studies showed differences in exam, EKG, or chest X-ray findings. 1 study found an average initial PaCO2 that was 5 millimeters of mercury lower than baseline in patients with PE, but this required patients to have baseline ABG, which in practice most don't. Lastly, 1 study found that patients with PE were more likely to have active malignancy or prior venous thromboembolism. Using all this information, here I've created a simple algorithm that I would like to propose for deciding which patients with a COPD exacerbation warrant workup for PE. First, does the patient have a history of malignancy or prior venous thromboembolism? If yes, then they need to be evaluated for PE. If not, what is the nature of the presentation? If it is atypical, for example, that is, it is characterized by very abrupt onset, no cough, a clear chest x-ray, pleuritic chest pain, and a lower than baseline PaCO2 if known, then that patient needs to be evaluated for PE. If the presentation, on the other hand, is typical, then just treat for COPD. If the patient does not rapidly improve, keeping in mind that almost all COPD patients feel better within several hours of treatment, at that point, evaluate for PE. However, if they do improve, and as they had a typical presentation, they are unlikely to have PE. Now we have just about exhausted the major components of the diagnosis and management of a COPD exacerbation. How do we know when a patient is ready for discharge? There is no absolute criteria, but things to consider include: are the patient's symptoms improved? Has the patient been on oral meds for at least 24 hours? Is the patient's oxygenation back to baseline? And is the patient able to ambulate without difficulty? Keep in mind, most patients will be appropriate for discharge before they feel like they are back to 100%. A couple of last thoughts prior to discharge. Anyone who is still smoking absolutely requires smoking cessation counseling. Does the patient require home oxygen? Most insurance companies require a patient to have a room air O2 sat of 88% or less in order to qualify for home O2. Finally, you should make sure the patient's vaccinations are up to date, specifically the pneumococcal and influenza vaccines. The importance of these often neglected issues cannot be overstated. Remember that smoking cessation and home oxygen for those who qualify are essentially the only major treatment modalities that have been shown to improve long-term survival in patients with COPD. All of the maintenance meds we prescribe for stable COPD only improve symptoms. They don't make people actually live longer. Alright, I've given you a ton of information and data, and I suspect you may be having trouble remembering it all. So here is a brief summary of the key points I've talked about. Diagnosing a COPD exacerbation is based on having an acute change in a patient's cough, dyspnea, or sputum production and/or purulence. Regarding management, albuterol and/or ipratropium should be prescribed for everyone, though good evidence is not available. If a patient is able to use good technique, an inhaler is just as good as a nebulizer. Otherwise, go with a nebulizer. Regarding steroids, just about everyone should get them. Oral prednisone is adequate for most patients, keeping in mind that while a patient is on continuous BiPAP, he or she should be NPO. The recommended prednisone dose is 30 to 60 milligrams for anywhere between 5 and 14 days, with or without a taper. Antibiotics are indicated if at least 2 of the 3 cardinal symptoms are present. Selection is based on likely pathogens, severity of exacerbation, risk factors for poor outcome, and local resistance patterns. A 5-day course may be as good or even better as a longer course. For hypoxic patients, you should aim for keeping an O2 sat of around 90 to 92%. BiPAP reduces the need for intubation, improves mortality, and decreases hospital length of stay. The benefit is more pronounced with lower initial arterial pH. And finally, a PE should be considered as either an alternative or additional diagnosis when risk factors are present, presentation is atypical, or if the patient fails to improve with COPD therapy. Thank you for listening. I hope this lecture has been helpful. Once again, this was Eric Strong of the Palo Alto VA Hospital and Stanford University. For more information about the diagnosis and management of COPD, I recommend visiting the website www.goldcopd.org.